Good evening, everyone. It gives me great pleasure to welcome all of you to episode 5 of the MMA Penang webinar series. On behalf of the MMA Penang Branch and the Women's Health Committee of MMA, I extend our heartfelt thanks to each participant for joining us this evening to discuss a significant and often under-addressed topic, which is heavy menstrual bleeding. This webinar series has been designed to provide healthcare professionals with a platform for knowledge sharing and collaboration, and tonight is no different. Our focus on heavy menstrual bleeding underscores the need for us as medical practitioners to better understand and address this common yet impactful issue that affects many women's quality of life. It is truly an honor to have Dr. Mairin a distinguished obstetrician and gynecologist from Hospital Seberang Jaya, as our speaker tonight. Dr. Mairin brings a wealth of clinical experience and insights to this session, and I am certain we will all benefit immensely from her expertise. I would also like to acknowledge the presence of Dr. Sivabala Selvaratnam, the chairman of the Women's Health Committee of MMA, who will be moderating this session today. Dr. Sivabala has been a driving force behind initiatives that aim to enhance women's health education and awareness within the medical community. Finally, I would also like to express my gratitude to the Women's Health Committee for their hard work in making this webinar possible. Let us use this opportunity to learn, to reflect, and enhance our practice in managing heavy menstrual bleeding with compassion and evidence-based care. Without further ado, I invite Dr. Sivabala to share his opening thoughts and introduce our esteemed speaker, Dr. Mairin Dulasi. Thank you, and I hope you have a productive and insightful session.
Thank you. Thank you so much for that very kind introduction, Dr. Divagar. Um, right. It gives me great pleasure on this Wednesday evening to witness that about close to 200 participants have taken time out on a busy Wednesday to be here with us this evening. And as Dr. Divagar said, it's the Women's Health Committee's initiative. It's in fact the first talk under the Let's Talk About series, which we have embarked on. So the chat box, a few housekeeping announcements. The chat box is open. Feel free to put in your questions for Dr. Mairin to answer. She would take us through heavy menstrual bleeding, and then after the session, she would take on questions from the floor. Now, a little bit about Dr. Mairin Dulasi. She's an obstetrician and gynecologist in Hospital Seberang Jaya, and she obtained her degree from the University of Dundee, United Kingdom, and subsequently completed her postgraduate training in UKM, University Kebangsaan Malaysia. She is passionate about teaching and had been involved with training of the undergraduates as well as postgraduates alike. She is optimistic that one day common sense will prevail. In the meantime, though, she will continue to raise awareness about women's health to anyone willing to listen. Now, let me tell you an inside story. I've had the pleasure of working with Dr. Mairin for slightly more than 4 years, an amazing speaker and an avid, very passionate person about women's health. Without further ado, Dr. Mairin, the floor is yours to enlighten us about heavy menstrual bleeding.
Thank you very much, Dr. Sivabala, for that kind introduction. There's a bit of a pressure now, but I'm sure we'll be fine. So let me just try and share my slides first. This is mine. Okay. Can you see my slides? Yeah?
Very clear.
All right. Okay, that's fine. So I want to thank the MMA one more time for just inviting me to be a part of this webinar on Let's Talk About Women's Health. So I'm going to show you these slides. If you look at these slides, what does it look like? What if I tell you that this is actually art based on a real menstrual blood. How many of you feeling a bit squeamish now, or maybe a bit uncomfortable, or you're probably a bit... That's the thing about menses, isn't it? Nobody wants to talk about it. I mean, we don't even talk about it among us women. I don't talk to my sisters about it. I don't talk to my mom about it. Even among working colleagues as a ONG specialist, we hardly talk about menses. And yet it is more actually than just a shedding of endometrium. When it's excessive, when it's not excessive, even if it's not excessive, women are already at risk for iron deficiency. But when it's excessive, there is an impact on the quality of life in so many ways. How many of you have ever looked at a child with autism and make the connection between this child with the autism to a woman that having menstrual bleeding? Because now there's actually very strong evidence to show that when women are pregnant with the iron deficient state, there is a risk for a fetal neurodevelopmental problem, and one of it is actually autism. So I hope you will be able to look at HMB in a different way after this talk. And that's why actually FIGO actually has a special committee on the menstrual disorders and related health impact. So most of the talk, whatever contents I'm having today, actually based mainly on this FIGO. They came out with this articles that is freely accessible. Have a look at it. And these are the contents of my talk today. So one thing I do want to make it clear, my main aim is just to raise awareness about heavy menstrual bleeding. So probably I won't be talking so much about all the different causes of it, because it is going to take us for another maybe different series altogether. But I do want you to understand heavy menstrual bleeding is important. It impacts women's life and beyond. And if there's anything that we can do in a general practitioner office, what can we do about it? All right. So just a little bit of an overview of heavy menstrual bleeding. So actually up to 50% of women has symptoms of HMB. And 2/3 of them probably are anemic or at least iron deficient. But if you look at the prevalence, if you look at the studies, it can be as low as 3%. It can be as high as 53%. Why is that? Simply because of how they actually define, or how they decided to say what is considered heavy menstrual bleeding. I'm sure a lot of us remember what is heavy menstrual bleeding. Traditionally, we say it is measured by volume of how much is the blood loss, more than 80 mils per cycle. But this is not practical at all. I mean, how many women actually have a menstrual cup and actually say, okay, this is how much of blood loss I'm having per cycle? Right? It's not easy to do. So actually NICE UK came up with this definition where it is more subjective. It is up to women to say what is excessive. And this definition has actually been adopted by FIGO, which is excessive menstrual blood loss that interferes with the woman's physical, social, emotional, and or material quality of life. So it's not just about how many pads that you use, but what is deemed excessive. But in saying that, there are still women who actually, their menses is actually interfering with their quality of life, but they didn't know that is excessive. So that's one of the things that we have to look at later on. Right. I'm sure you're very familiar with these possible causes of HMB, which is palm coin. Palm part is a structural part, which is polyps, adenomyosis, leiomyoma or fibroid malignancy, and then you have coagulopathy, you have this ovulatory dysfunction, endometrial, iatrogenic, and when we do not know how to classify it, and then we just say it's not otherwise classified. But these are the possible usual causes of heavy menstrual bleeding. So why is it important for us to talk about something that is supposedly physiological in half of the population of the world, right? So one thing is when women has heavy menstrual bleeding, actually maybe intermittently, but some are even more frequent than others, but it directly affects women's physical, social, emotional, material quality of life. If you look at this short form quality scores that they look at mental health, role, physical functioning, bodily pain, they actually score significantly lower. And not only that, they have fear, embarrassment, they don't wear certain clothing, they have to be careful about it when they are somewhere else. So it does affect women directly, right? And then just I think 2 weeks ago, I was just looking at the internet. I found this. There is a paper to suggest there's an association of a heavy menstrual bleeding with cardiovascular disease among young women in the US, female hospitalization, those among less than 40 years old. So if this is true, then that is a bit scary, because if you look at the principal causes of female death in Malaysia in 2023, a lot of it has something to do with, related to cerebrovascular or cardiovascular diseases. And this paper earlier that was mentioned about they actually said probably HMB should be used as a risk stratification just to look at these women whether or not they have all these problems, right? This is what I call the evil twin of a HMB. Because when women have heavy menstrual bleeding, a lot of them actually suffer from iron deficiency. But there is very limited data on the true extent of relationship between HMB and ID. I call it ID or IDA, because even HMB, we don't report that much. We fail to recognize it sometimes. I mean, women fail to recognize it. And there is no healthcare policy about direct screening for HMB or even iron deficiency in a HMB woman. And yet, when iron deficiency is present, even in the absence of anemia, it actually erodes the quality of life of these women every day, not just intermittently. Most of the time, I think a lot of us equate iron deficiency as anemia, but that's not true. Iron deficiency can be so bad before women started having anemia because of that HMB. Somebody actually came up with this particular diagram where they actually make a correlation between the serum ferritin and what kind of symptoms women with heavy menstrual bleeding will have. And if you look at definition of iron deficiency, they said when the serum ferritin less than 30. But you look at when the serum ferritin about 70, there is hair loss. At 50, fatigue, brittle nails, 35, frequent infections. And then at 30, when you actually say this is iron deficient, headache, depression, concentration, impairment. And when you look at when actually anemia happens, it is when it's almost depleted in iron. There is 5 in ferritin. So I just want you to understand that iron deficiency, when HMB women have anemia, they are probably severely iron deficient, right? So don't look at anemia to say, oh, this must be a very bad heavy menstrual bleeding, because there must have been, the anemia only happens because iron deficiency has already been so bad. And you may be thinking, but iron deficiency shouldn't be a problem. But that's not true. Because if you look at the role of iron in human body, it's not just erythropoiesis. It's not just about red blood cells. It's in nervous system, liver, kidney, heart, mitochondria, skeletal muscle. It affects so many other system and functions in the bodily, in the human body. So when you have iron deficiency, all these things will be actually affected as well. So that's why the diagram, if you remember earlier, they started showing all these symptoms long before they actually started having anemia. So do not underestimate the impact of iron deficiency in a HMB women, because they can have the symptoms similar to those with iron deficiency anemia: fatigue, exhaustion, brain fog, shortness of breath. If you see somebody with restless legs or maybe pica, suddenly they have this craving to have ice or dirt and all that, probably should check them for iron deficiency, even if they don't have anemia. And then in adolescent, school children, there is evidence that iron deficiency alone, because of HMB, can be associated with both physical and cognitive impairment, and treatment with iron. This is patients without anemia has actually been shown to improve function. And there's actually a study in Klang Valley. It was done among adolescents in the school population. So 28% of these students had HMB. They scored lowest in the quality of life scoring, physical health functioning, psychosocial scores. They are depressed, and there is a direct negative impact on their school and social performances. So I'm sure you and I can agree that when there's a heavy menstrual bleeding, and especially when it's, as you said, iron deficiency, because whether you like it or not, there's still a lot of women, adolescents out there that is also facing the problem of food insecurity. So that is the negative impacts of quality of life. One of it is economic, and the also multiple function role that women actually play in the society. So all this is going to be affected as well. I mean, what is the cost of menstrual products? And probably they're thinking, oh, I'm feeling tired all the time. Maybe I need vitamins, or I'm losing my hair. Go and buy hair products. And then women who are actually working, either they have to take MC or they feel so bad, even though they're not feeling well, but they still come to work, but they're not actually giving it 100%. So it is affecting the quality of life of women. And if if there is anemia, not that is just iron deficiency. When they have anemia, the symptoms can be more severe. And if they have any comorbidity, symptoms might become worse and prognosis might become worse as well. And what if, as we've seen earlier, HMB, some of it is because of a structural problem. Let's say they've got fibroid. They have to go for surgery for it and they're anemic. This increases their risk of a perioperative morbidity and mortality that may not be mitigated by blood transfusion. And another thing, I mean, we'll be thinking, oh, this adolescent, young women, but what if they are HMB, we didn't recognize it, and then they have iron deficiency, and we thought they are not a problem because there's no anemia, but now you and I know that anemia is probably when the iron is so depleted, and then they go into pregnancy where there is an increased demand of iron, and then iron deficiency is going to be worse. They have anemia, and these all have adverse impact on mother and the fetus. Mother, preterm labor, preeclampsia, abrupt show, PPH, and then the fetus is going to be preterm FGR. And as we have mentioned earlier on, this neurodevelopmental adverse impacts, low iron stores. So the baby might need extra care, and yet the mother had depression, fatigue, impaired cognition. They cannot really breastfeed their baby. And then it just goes on and on. And if you look at this, I'm not going to read through all these things, but you can see there is a short and long-term neurodevelopmental consequences of fetal iron underloading, and all because we failed to recognize that the women had heavy menstrual bleeding, had iron deficiency, and then went into pregnancy, and then there is a fetal underloading, and then postnatal, they have neurodevelopmental effects. And there's no benefit even when you try to give this newborn with postnatal supplementation. So that's the sad thing about it. So I'm hoping I'm at least able to convince you to look for heavy menstrual bleeding and its evil twin, iron deficiency in women. Right, the challenges is why are we missing out on all these things? One of it is because of a normalization of HMB. I mean, not just in the women themselves, in the family, even when they come to us, we think, it's not really a problem, we just part and parcel being a woman, blah, blah, blah. And it's a taboo subject. Nobody really wanted to talk about it, right? But I do hope we will change our mind, because if you look at the journey of a HMB woman, it took 3 years before they themselves took the first action. And yet when they come and meet their doctors, at the end of the day, only about, if it started with 100 of them, probably only 20 was actually diagnosed. And out of this, only 7 received treatment. And if they do receive treatment, actually the successful rate is quite good. I mean, about 70%, at least in this women that they actually studied in this study. But it is sad, so many remain undiagnosed and untreated, right? And yet women do want to talk about it. They do want to have a bit more conversation about it. But sometimes maybe we as a healthcare provider, we don't really give them that chance, or we don't really look for opportunity to look for it. So is there anything that we can do, right? One of it, so that's why we're having this webinar. We are trying to create awareness that heavy menstrual bleeding, it is real. It is more common than we think. It does have impact on women's life, and even beyond them. How is it going to affect society? How is it going to affect their children, right? So hopefully we have this awareness. I'm hoping it will lead to early diagnosis and timely and appropriate treatment for these women before it become too bad. So what can we do? First thing, maybe detection and diagnosis, right? So when it's directed, it's always a bit of a problem for us, because either women don't come or we don't really do it. But opportunistic, I think we should screen women for HMB, especially those. I mean, if somebody comes to you in a reproductive age, right? They might be not coming with the heavy menstrual bleeding. They might be coming with the symptoms suggestive of iron deficiency, even if there's no anemia. I mean, you have a teenager, school children. I'm feeling tired. I cannot concentrate at school. And why not just check them out? Could they be having heavy menstrual bleeding and check them for iron deficiency? Those who are about to embark on a pregnancy. So even if it's during pregnancy, maybe it's too late for heavy menstrual bleeding at that time, but at least for the iron deficiency, because of the heavy menstrual bleeding, there is still something we can do about it, or those they are going for surgery. And how do we screen? It doesn't run away from history, examination, investigation, but probably what is it that I want to one of the things that we can do is Figo actually came up with the two systems. I mean, if you don't like it, that's fine, but you can Google it. It is readily available. So the system one is actually more of a symptoms. The other two is a potential causes, the palm coin that we went through earlier on. So in this system one, they actually ask about the frequency, duration, regularity. So it's just trying to see where things are being normalized by women and girls and even us, right? So it's very easy to follow. But let's say it's a bit, maybe you don't like it, then there is actually somebody who came up with this Samantha questionnaire. So they said if the score is 3 and above, that probably indicates that the woman may have HMB. So what did they look at? Do you bleed for more than 7 days a month? Do you have 3 or more days? Or do you find your periods particularly uncomfortable? Or are you worried they're going to stain something every time you sit or change during the night? So these are the things that you can actually ask women. Because sometimes they may not say it's a lot, but they are worried about it. They are carrying menstrual products everywhere with them just in case if they have they started bleeding a lot. And it doesn't do, I mean, it's quite good in sensitivity, specificity, PPV. It's just some kind of a screening question. And again, this one you can just freely Google it and it's available. You can find it. You can use that. So we have to move away from just asking about quantity. I think we also have to ask how is it affecting her life. As I said earlier, sometimes on certain, maybe during the menses, they don't want to go out, or if they are going out, they won't wear any white pants, it's all black pants, baggy shirts, and maybe they have to change their sanitary protection during the night. So ask them about these things. So they're worried about it. Another thing is look for maybe indirect symptoms. As I said, the evil twin, which is iron deficiency, they might be coming to you with feeling fatigue. They might have restless leg, difficulty sleeping. So why not just ask them about, I mean, if you're checking them for iron deficiency, if it's low, or even when they're anemic, just think about heavy menstrual bleeding as one of the possible causes why they are like this. I mean, just imagine school children unable to concentrate at school, and they are too, I mean, they're fearful, they are feeling shy to talk about their problems, right? So why not just ask them? And then, of course, we can always look for all the structural causes or non-structural causes. It's still the same old thing. I mean, you can do a scan. If you have maybe endometrial sampling in your clinic, maybe you can get it done. Always take the chance to do a pap smear. So these are all good. But probably one of the things that I just wanted to highlight is, please, if you find somebody with heavy menstrual bleeding, please screen them for bleeding disorders, because 1/3 of adolescents with HMB probably have disorder of hemostasis. In fact, 13% of women with HMB probably ended up with the von Willebrand disease. And it's very easy. Positive screening, just ask any of these following. Maybe they have heavy menstrual bleeding since Menake, or one of these following, or two of these following. Think about, could this be a bleeding disorders? And you can just do this very simple test to actually see whether or not they have brain disorder, and maybe if it's a problem, refer them to hematologist. Is there anything else that we can do? Right? It's the same thing. If you can actually diagnose heavy menstrual bleeding, you can stop the leak. But at the same time, you have to fill up the tank as well. And that is when you diagnose whether or not they have iron deficiency. And again, I just want to remind you, even if it's without anemia, because if you remember the diagram earlier on, it's almost depleted. The ferritin had gone down to 5. Then only they actually have anemia. And not only treat them, but actually monitor the response, right? So for heavy menstrual bleeding, of course, there is medical, there is surgical, procedural that you can do. Maybe procedural, there are not many that you can do in your practice, but at least for medical management, And treatment, you always have a lot of choice, depending on the cost, impacts on quality of life, their fertility plans. But I'm sure antifibrinolytics, tranexamic acid, NSAIDs, COC, these are all readily available, and you can actually give this woman this medication. And if you look at how does it actually reduce the menstrual blood, I mean, it's quite good. And some people actually use antifibrinolytics and NSAIDs together, especially they have dysmenorrhea, and actually good, even better. It almost have a synergistic action, if you can say so. But for tranexamic acid, I noticed a lot of, even me, early on, I just give them about 500 mg TDS, but probably it's not enough. This is from Cochrane actually, and what they do advise actually 1 gram. I do not know whether in your clinic do you have your capsule is 250. Our hospital is only 250, so women actually have to take 4. But it's okay if you want to start with 500. But if it's still not working, by all means, go to 1 gram TDS. Mefenamic is the same, and even for COC, you can actually ask them to just continue taking it for 3 months without stopping in between. It's not a problem. It doesn't cause any problem, in fact. And of course, you have progestogens. I'm sure you'll have at least some of this in your practice. I mean, if they want contraception, there is Mirena. You can put it for 5 years. I know for contraception it's about 8 years, if I'm not mistaken, but for heavy menstruation, it can be used up for 5 years. But one of the things probably, if you are using progestogen, I think it's very important to tell women, adolescents, that they might notice there are certain side effects. Maybe they have a bit nausea, vomiting, not all of them, and also irregular bleeding, especially in the first 3 to 4, 6 months. So tell them, just like if they're taking this Mirena, the first 3 to 4 months, it might be a bit more, they may not like the bleeding pattern, but if you tell them what they can expect and what do you expect to find, because you see by 1 year, there might be quite a number of them that actually even doesn't have amenorrhea. So I think it's important to tell women what to expect and to tell them if there's any problem, please come back and see us. There are other things that we can try out and see whether these things works better for you or not, like Dynogest. If they have adenomyosis, it's really better for these women, right? This is just for comparison. I'm not going to read through it, but feel free to have a look at some point if you do want to have a look at it. And then if they do have structural problem, or even if it's non-structural, that we can do something about, please refer to us as soon as possible. So that's why it's important to look for the causes, but you cannot look for the causes if you fail to detect that the woman actually have HMB in the first place, right? So now the second part, to take care of the evil twin, right? So I will sound like a broken tape, but if there is a woman with heavy menstrual bleeding, even if they don't have anemia, please, please, please screen them for iron deficiency. And then you can actually treat them. This is just, I just want to compare between iron-rich diet, oral iron, parenteral iron, because a lot of us just tell our patients, okay, your iron is a bit low, just take a lot of liver or take a lot of this. But sometimes we forgot about the absorption. In a plant-based iron, it's only 5%. Meat-based iron, 25%. So if I'm just giving you an example, 1 kg of bayam, I don't know whether there's anyone who's actually taking bayam for 1 kg. There's only about 27 mg iron. So this will be equivalent to the iron that's going to be absorbed if you take 200 mg of sardines. So it's very, very low. So if you want the iron to be, you have to replace it quickly, then this may not be enough. So there is oral iron. This is also good. Typically absorption about 10%, but 30 to 50% may suffer from GI side effects. And then now there's also parenteral iron. Because parenteral iron, you can actually administer via single infusion up to 1,000 and rapid correction of iron and functional improvement reported within 48 hours. I'm not saying anemia will be within 48 hours. It might take about 2 to 3 weeks, but the iron is already replaced. So those who have iron deficiency, they actually reported that within 40 hours, there are functional improvements. So this is something that we can look into, right? So for oral iron, please have a look at the elemental iron. And then the HB increase probably usually about 4 weeks, you might be able to see 1 to 2 gram for deciliter. But if you are not monitoring their iron, I'm doing serum ferritin, then at least when the anemia is already, it looks like anemia is already resolved, please continue your iron supplement for another at least 3 to 4 months, because the repletion of the iron store may take that long. But what I do want to remind you, when you're giving iron tablets, just because you thought the more iron tablet you're giving, it'll be better, that is not true, because of this hepcidin. When there is a low hepcidin, like in a patient with iron deficiency, it promotes iron absorption and release. So what happened when you give, if you can look at this, the conclusion from studies on oral iron in ideal women, the more iron deficient they are, maybe they'll be able to tolerate higher dose for oral iron. But when you give too high, it will trigger an increase in hepcidin. It can persist for 24 hours. It's only after 48 hours it subsides. So if you do give them higher iron, they may not be able to take all of it. Another thing is, there's a circadian increase in circulating hepcidin. So if you give oral iron in the morning, it will increase throughout the evening. So even if you decided, okay, how about giving this patient Ibarat, one in the morning, one in the evening, it's not going to help them at all, because it is not going to be absorbed very well. And in fact, what they're going to get is just going to get more side effects. And that probably will stop them from taking more, right? So more is not always better. If you do want to give a higher iron dosing, give EOD for better absorption. Actually, there are many studies to say that giving EOD is just as good as you giving every day. In fact, probably absorption is better. But if you prefer to give it daily dosing, maybe you're worried women will forget to take it if it's EOD, then give it in a lower dose in the morning, less than 40 mg. So better tolerated and improved compliance, right? And this is another thing, parenteral iron. I do not know whether any of you are actually practicing this in your practice, but in the clinic kesihatan, there are actually some who are actually doing it. So they can give it as an outpatient procedure. It can be as fast as 2 minutes, depending on the type and how much you want to give them, and the rapid increment of hemoglobin, probably in the first 4 to 8 weeks, and of course, adequate iron. So as I said just now, if it's just iron deficiency, because I've seen, I've listened to some of my colleagues, my hematology colleague, they actually have teenagers who came in with iron deficiency, and they give them, and they tried everything before that didn't really work. But when they actually noticed that she had iron deficiency, they give parenteral iron. Actually, it's remarkable how good the adolescent felt afterwards. So maybe, I don't know, maybe some of you would like, this is actually a clinic in Singapore. They started as the iron suites. They actually just give iron for patients. I think that they were doing so well that they actually now introduced the integrative medical center as well. So probably this is something that is worth looking into. But that's the thing. First of all, we need to be able to see whether they have heavy menstrual bleeding, do they have iron deficiency, and these are the things that we are going to do. But one of the things, probably before I end, I'm almost at the end of my talk today, communicate with these women, these adolescents. Talk to them. What are your treatment goals? I mean, one of it, if they do have HMB, we want to try and stop the bleeding. And if there's any structural or anything that needed to be referred to somewhere else, please refer to them. And then if there's any treatment, especially those with probably with quite a lot of side effects, or they may not be able to see the effect immediately, like you're taking progestin. Sometimes it takes 3 to 4 months before it actually works. So talk to them. What to expect? Is there any other side effects? And then tell them that we might have to revise our strategy. Maybe you want to give them appointment, or just tell them, okay, why not? If you have any problem, come back and see us as soon as possible. We talk about any other alternative treatment that is actually available, right? So check work message, heavy menstrual bleeding is very much underappreciated, often normalized. And then its evil twin is also suffered the same thing, and despite it being highly prevalent, undermine the quality of life, it adverse impacts even to the fetus, and they're growing up as adults in the society. So probably we are thinking it's just heavy menstrual bleeding, why should we care? But there is impact in so many other different ways, right? So I do hope that by having all these series, I do hope it will raise awareness. Maybe some of you have teenagers at home, or maybe sisters or female friends, and they're talking about I'm losing my hair, I'm feeling depressed. How about just think about HMB, stop normalizing it. Look for possible HMB among adolescents. Screen if there's anyone that you meet have anemia, even if they deny they're having HMB, please screen. There are so many questionnaires that you can use to actually ask them whether or not they have HMB. Because you'll be surprised to see there are women who are running around with 7 and 8 gram of um, hemoglobin level. And when I ask them, do you have heavy, is your period problem? Yeah, no, it's normal. But you actually ask them all the other things, we're already quantifying it, it's actually heavy menstrual bleeding. And if you do find somebody having menstrual bleeding, please screen them for iron deficiency. Don't wait until they have anemia. Appropriately, promptly treat the HMB and its underlying cause, and also the ID and idea. With that, I thank you. So there you go. Thank you very much.
Thank you so much, Dr. Mairin, for that very well designed presentation. And when you started your talk, you see all that applause and love going up there. When you started your talk, you had about 200 participants listening in. And now I'm
Right.
happy to say there are more than 300 attendees online with all that love being sent to you. So thank you so much. We've
Thank
got
you.
some questions. So
Sure.
question number one, right, from our
Yeah.
participants tonight.
Right.
When sending blood to the lab, do we do iron level or ferritin?
Okay, if you're looking for iron deficiency, actually, probably you should do at least ferritin. But the problem with ferritin is, it's a very labile. If you're having infection, you're having some kind of a inflammatory disease, it will be increased. So if it doesn't cost so much, it's better for you to send ferritin together with transferrin saturation. Because transferrin saturation, if it's less than 20%, even if your ferritin is actually more than 30, the patient probably have iron deficiency. And also just probably now, I know we are looking at less than 30, but even if it's less than 100, I would say they have a low iron stores, right?
Right. Thank you. And I hope that answers the question. The next question is, you mentioned contraceptive pills as part of pharmacological management of HMB. Is
Yeah.
there a difference in outcome between COCP and POP?
Um, Probably it more depends on how you're actually taking it. And then everyone react differently to different things because POP is also good. But the thing is you have very short window of how you have to take it at a certain time, at the right time. So not much difference. But COC probably have a bit better. The only problem is because if you are using POP, right, it's better for you to use all the other progestins. The one that is a well-known, the NET, norethistotron, sorry, I can't even pronounce it right. They have at least they want to have studies. I haven't really seen about this or other mini pill, but NET, Provera, they have a better studies to show that they work just as good as COC. I hope that answer your questions.
Uh, Definitely. And then the next one, interesting here. May I know the maximal duration to prescribe antifibrinolytic and NSAIDs? Is there increase of VTE if given longer duration?
I don't really have much data on it. I don't really study it. But if you look at the Cochrane review, for tranexamic acid, they only give it for about 5 days. I'm not sure if you get beyond, would it increase or not. But actually, from what I know so far, there is very little evidence. If they are not at risk for DVT, it shouldn't cause DVT. But probably I wouldn't go beyond 5 days if it's going to work for a woman. If it's going to work within 5 days, try and keep it in 5 days. Unless they really need it, then you probably have to revise your treatment strategy on what to do.
Right. And I like this question because it comes from a very wholesome perspective. So one of our
Okay.
participants would like to know, should we encourage use of cast iron pot for daily cooking?
Okay, I'm at loss. Yeah, I'm not sure. I don't know how much of it. I mean, if it's going to increase the iron intake for women, I'm all for it. Do whatever you can do. In fact, I think all women should take at least 1 or 2 tablets of iron every week, as long as they're menstruating. So, by all means, I'm a fan. Do it.
No, but cast iron pot, right? I believe it should not be construed as a substitute for treatment,
True.
because
Yes.
I don't think there's anyone out there who has done that study to show the iron that's coming off the pot is adequate to
Yeah,
supplement iron deficiency.
that's
So
true.
if it floats your boat, I'm with Dr. Mairin. Go ahead and cook your food in that iron cast pot, but cast iron pot, but it should not be sold to patients to treat iron deficiency, I would think.
Yeah, that's true because it won't be enough, right? It won't be enough.
Yeah, yeah.
Yep.
Um, Next one. I think, Dr. Myrin, you had a very nice slide about palm coin, because our participant would like to know
Ah,
if you could list the common causes of HMB, which I think was very nicely showed in that slide of yours.
right.
Is there a chance that we could just get back that slide to that particular palm coin?
Okay.
And if you can share slide again for the benefit of this participant,
Wait,
because
yeah.
all the from ops and gynae perspective, right? That one slide would um, give you all the possible causes or the commonest causes
Yeah.
for HMB.
Let me try and find it. Where are we? I'll go to right to the beginning. Aha. There you go.
Yeah, thank you. Um,
Okay.
yeah, brilliant,
So,
brilliant. If you can,
right.
for the doctor who asked about this
Mm,
question, if you can take a screenshot of it, it would be brilliant, because there you have it in
yeah.
one snapshot.
Mm,
Um, what needs to be done, more or less, as well as the palm and coin components of the HMB causes.
yeah.
Dr. Marin, anything else to add on that slide
Probably,
with
I mean, the
regards to
most
causes?
common, yeah, causes. There's nothing, it's actually pretty much, I mean, if it's not any of these classes, right, it will always be not otherwise classified. There you go.
Mhm.
But it's all here.
Yeah.
Probably the one that I was talking about just now. I mean, there are a lot of them probably, if they have dysmenorrhea, think about adenomyosis. There might be fibroid, if a bit. Malignancy in a younger age group, probably not so much. But if they have polycystic ovarian syndrome, nulliparا, their family history of malignancy, then think about malignancy. But all these things are quite, I mean, if you just do a bit of a maybe scan or asking history, especially for coagulopathy and ovulatory problem, then you probably will be able to get the diagnosis at the end of the day.
I
Right.
think it comes back to the hallmark of medical school, which is history
Yes,
and examination, and
exactly.
then half your half
True,
your diagnosis is already in history and examination.
true.
Um, the next participant says, "Hi, doctor. Thank you for your informative talk." And the question is, for medical um therapy, right, in HMB,
Mm, mm,
I've read that cyclical mefenamic acid is the first line. Mefenamic and tranexamic acid is the first line. How long
mm-hmm.
should a patient on cyclical mefenamic and tranexamic acid be put on?
Right. So if you can see, can you see this? Right, right. So if you look at this, yeah, this is tranexamic acid and NSAIDs. These are the, so if you look at this, maximum duration of use is 5 days from the onset of a heavy bleeding. So that's a cons of it. It's not like you're going, because they don't have much study. If you go beyond, is it going to affect more problem? As I think we talked about it earlier. So these are the things. Are you talking about the duration? Duration is 5 days, but you can use it for every cycle if you need to, as long as they don't have any other um, contraindication for it. I mean, if they have peptic ulcer, of course, you're not going to give them NSAIDs, right? They have DVT, you're not going to give them tranexamic acid. But otherwise, this is what is written here. Maximum duration used, 5 days from onset of a heavy bleeding, but you can use it for every time they're having bleeding. All right, does it answer the questions? Yeah,
I believe it does.
okay.
Because there's no real, I believe there's no real study to say that it can only be taken for an X amount of time. Because as
Yes,
long as
that's
the
true.
woman is benefiting
Mm-hmm.
from those cyclical use of tranexamic
True.
and mefenamic acid, I
Yeah,
believe the benefits outweigh the risk, really.
yeah, correct.
Yeah.
Yeah.
And is there a role for early iron supplement in women diagnosed with HMB even before anemia develops? if iron result was normal, would be the next participant's question.
Right. Okay. So I quite like this iron. I mean, even if it's normal, it depends on what you say normal. As I've told you earlier, um, iron deficiency is when serum ferritin is less than 30. But actually, if it's less than 100, even though it's still considered normal, but it's actually low iron stores. So I think for this kind of women, you should still give iron supplements for them because we wanted the ferritin to be at least 100 and above. And another thing is, if you're just looking at iron, you say iron study is normal. Are you just looking at the ferritin, or are you looking at the transferrin saturation as well? Because with just ferritin, as I mentioned earlier, it can be affected by other things as well. So that's the thing that's going to check. So if you are not going to give them, maybe not iron supplement, but at least still make sure that they are taking enough iron at least in their diet, because you do not know when the iron is going to deplete further if you are not stopping the leakage. But if you're stopping the leakage, then by all means, maybe they don't really need the iron supplement. But be careful about what you mean by normal. That's my main point actually. And be careful, just because you do one today doesn't mean they will stay non-iron deficient for the rest of their reproductive life. So just monitor that as well, as long as they're still having menstrual bleeding.
Thank you. I'm sure that has answered that question. The next question is, yep, you've got a thumbs up for it. What
Thank
can
you.
we do to patients whose bleeding doesn't stop even after giving tranexamic acid? What can be the causes of HMB in this case? I think it
Right.
comes
So
back to your slide
yeah,
earlier, right?
yeah. That's the thing. So it's very, very difficult. So that's why some patients, tranexamic acid, but depends on how much tranexamic acid you're actually using. Some people just use 250, 500, but it can be up to 1 gram. So check that one out. And are they taking it correctly or not? There are some patients, they said, oh, it's not so heavy. But when you ask them, what do you mean by not so heavy? It's actually already heavy. Then only you started taking it. They should have taken it when it first started being heavy. That's another thing. So if it doesn't work, then you have to think about any other medication that I can use. It's not so much about of the cost. Of course, you have to look at the cost. I mean, if it's because of fibroid, probably you have to remove it. If it's polyps, you have to remove it. But if it's not, especially if it's just ovulatory, then you probably have to think about giving them something else. Maybe it's a COC or one of the progestins. So it goes back to what is the cause behind it? How are they taking the tranexamic acid, right? Even doing all this, it might still not work. So that's why it's very important to revise your strategy. If you're not sure why is this happening, then give us a call. Or if you think it's because of a bleeding disorder, call the hematologist. All right?
I completely agree. In fact, when I was looking at the question and you were answering it, I was thinking, when nothing works, what do you do next? So you've gone through the steps, the motions,
Yeah.
but I still think that it has to be a low threshold to pick up that phone or write a referral letter
Yeah.
and send over to the obs and gynae.
True.
Um, and interestingly, there's another question which goes, what can we do to actually uh, better manage HMB women between primary care and obstetricians and gynecologists? Are there um, pathways in place, or would it be just a conventional referral letter, or how can we enhance collaboration between primary healthcare providers and obstetricians and gynecologists when managing women with
Mm.
HMB?
I think it's very important, as you rightly pointed out, there should be a better collaboration between the primary care and also the hospital care. But I know it's not always smooth. I mean, if you look at, I'm talking from a government hospital perspective, right? You have to take a referral, you have to call us, and then our appointment is only like 3 to 4 months later. But at the end of the day, if you can able to, I mean, if you are not persistent, in a way, if you cannot get through, because sometimes when you call us, it ended up with a staff nurse in the clinic. Call the doctor. You cannot get a doctor if you think you need um, just call the specialist. I'm sure, I mean, they might be grumbling in our hearts, but at the end of the day, he wanted the best for our women, right? So that's the only way. I mean, I don't know how it works in a private. Probably it's a bit easier because they need to pay, right? But for government, it's a bit more difficult. But I don't know. So maybe, Dr. Siva, how about giving us your 10,000 ringgit worth of opinion then? Not 2 cents, huh? 10,000 ringgit, huh?
10,000 ringgit, what?
Worth of your opinion. I mean, how are you going to collaborate these things better? Because I do know that there are problems trying to collaborate things between the primary and the hospital setting, right? It's not so easy. So
Yeah.
that's the thing. So
I think we have come a long way since whether it's 5 years ago or not.
yeah,
I believe most tertiary hospital or even clinic kesihatan have got this policy which we say there's no wrong door policy. But having
yeah,
said that, the ground reality is, as what Dr. Myron rightfully said, which is sometimes it's very difficult to get the women the early
mm,
appointment that
yeah,
we need them to get. So then it comes back to clinical evaluation. If the lady
mm,
is already breathless, then we are not going to write a referral letter and wait for 3 months, right? I
yeah,
would think that we should just guide them that you know what, you're already breathless, you may actually need blood transfusion or iron transfusion, parenteral iron, enteral iron. So you best go to emergency department since because the next available appointment for your heavy menstrual bleeding is 3 months away, and I don't
yeah,
think your symptoms are going to permit that. um, but it's on a case-to-case basis, really. So
mm,
we, at the same time, we do not want to clog emergency department. That is not. It's already overwhelmed.
yes,
Those are the ground realities again in government setting. Emergency departments are overwhelmed, and we do not want to contribute to that. But um, I believe in Dr. Myrin's presentation, she already pointed out that we need to fill up the tank, which is to optimize the iron. So early detection and open channels, clinical evaluation and timely referral, not keep them until they are breathless. Then we say, you know what, I think now it's time for you to go to ED. So it's a balance, lah,
that's
really.
true.
I mean,
Yeah,
yeah.
yeah. If you're not
Um,
sure, just give us a call, right?
yeah.
Yeah,
Exactly. One
mm,
phone call away. By the way,
yes.
Dr. Myrin works in hospital Seberang Jaya, and
Hey,
and she's serving there for as in KKM for more than 20 years, I would think. And I'm
yep.
currently serving in hospital Raja Permaisuri Bainon. For those of y'all who are not sure where that is, it's Hospital Ipoh. Back in a long, long time ago, it used to be called Hospital Ipoh. So, next
Yeah.
question, Dr. Myrin. Um, when would you use Ibret Colic, and
Mm,
when would you use Sangobion? Which preparation has the lowest incidence of GI effects?
mm,
Disclaimer, Dr. Myrin does not have shares or own any shares in Ibret
yes,
Folic Company or even Sangobion. We are not even
exactly.
sure whether it's the same company or not, but I highly doubt it. But yeah,
Right.
go ahead, Dr. Myrin.
So, if I mean, Sangobion, the elemental iron is about 30 mg. Ibret is 105, so it's higher. So, if it's iron deficiency, um, it's probably better to give, especially when they have anemia, right? Ibret is probably better. And I know Ibret claim that they have less GI side effects, but I tried it, and I even took it at night when I do not know that I'm supposed to take it in the morning. I woke up at 2, 3 a.m. in the morning to vomit in the toilet bowl. So I'm just saying, not everyone will react the same way. So sometimes it's a bit of a, it depends on why are you giving it for? Is it for iron deficiency? How bad is iron deficiency? How fast do you want it to be better? Because if it's iron deficiency with anemia, they may be able to tolerate 100 mg without increasing the hepcidin. But if it's iron deficiency, if it's more than 60 mg, it will increase the hepcidin. So increase the hepcidin, is better for you to give it every other day. So if you give every other day, then the side effects won't be so bad. But if you get Sangobion, it highly increases your hepcidin. So again, that's why it's important for you, whichever you try, go back to your patient, tell them there might be side effects. If you are not able to tolerate, please come back and see us. And then you can actually adjust their iron supplement. So sometimes you just have to try, right? Does it answer the questions? I hope so. Yeah.
No, I believe it does because
Yeah.
bottom line is one size, yes, you've got a thumbs up for it. One
Okay.
size does not fit all. It has to be
Yeah.
individualized. You see,
Right.
although Dr. Mairin has spoken about her adverse effects with Ibarat, was it?
Yeah. But not
Yeah, but
everyone have that problem.
yeah, not
Yeah.
everyone is going to have that, and some
Yeah.
people would swear by Ibarat, and it's been like the perfect wonder
Exactly.
drug for them.
Yeah.
So, individualized treatment, right? So,
Mm.
next question is, how about using Sonulat till bleeding stops, for example, for a week?
Okay. What is Sonolet?
Okay.
I'm
Thank
so
you, because
sorry.
I was in the same boat as you, Dr. Mairin,
I
but
was about to
because
like,
you
okay,
were
Dr. Siva, can you
speaking.
please answer these questions? I have
Yeah, so
no idea what
I,
is
I
Sonolet.
sort of Googled what is Sonulat because in GH, right, to be frank, in government setup, we have not heard this thing called Sonulat. But Dr. Myrin, Sonulat is actually no retisterone.
Ah, right.
But it's
It's
just the
actually very
brand name
good.
is
Yeah.
Sonulat. So I Googled it while you were
Yeah.
answering the other questions. So can we use no retisterone
Yeah.
till the
Yeah.
bleeding stops? For example, for a week.
Yeah. In fact, if you look at the dosage they give, it's from day 5 to day 26, if I'm not mistaken. So you can actually give it even for 3 weeks. It's not a problem at all. So it's one of the treatment actually being used for HMB for those who can use it.
Right. Next question is pretty interesting. It's very offbeat. So thank you to the participant for coming up with this. Patients, right, sometimes ask whether it is safe for coitus during heavy menstruation. How would we advise these patients?
I mean, it's really up to their preference. I mean, are they comfortable or not at the end of the day? From medical point of view, or at least from gynecologist point of view, I have no problem whatsoever. If they're gonna have sexual intercourse while somebody's bleeding, comfortable with it, by all means. At least you know you won't get pregnant, right? So,
Yeah. Disclaimer, obstetricians and gynecologists do not have control over what floats people's boats. So if it floats your boat, by all means. No
go for
evidence
it.
to say Cochrane has not yet embarked on a study to say there are adverse effects of coitus
Yes,
during heavy menstruation. So,
true.
yeah, there you have it. Next up, we have, do we give both tranexamic acid and mefenamic acid uh, together and adding PPI? I love it that our participants also have a sense of humor because I see those emojis coming up. So it's not just me having fun here with these questions, but thank you to the participants who are still around. So next question, do we give both
Yeah.
tranexamic acid and Constant together and adding PPI? Thank you.
I mean, okay. I mean, tranexamic and mefenamic acid, actually, there are some who say that if you give it together, they work synergistic. Okay, I can't pronounce it. I'm sure you know what I'm
No, you
trying to
got it.
say.
Synergistically.
Yes,
Synergistically.
thank you. Right. But
Yes.
for PPI, I mean, why do you need PPI in the first place? Is it because you're worried they're going to have ulcer? Then if there's a problem, then probably you shouldn't give mefenamic acid in the first place. But I do know there are people who are worried about it. You want to give, it's not wrong, but if you don't need it, why give PPI if there's no other reason for it? But just the two drugs together, you can actually give it together. It's not a problem at all. Right.
Right. Before taking the next question, right, I'd just like to tell our participants, right, it's almost 9 p.m. and we've got a few more questions, lots of brilliant questions, and I hope you find them funny as well and informative.
Okay.
Um, but I'm just amazed in the last 1 hour. Thank you, Dr. Myrin, for making it so cepat dan tepat Malaysian style. And,
Yes.
for still, everything jam-packed within 1 hour, lots of hearts going up. So thank you. And not just questions, right? For the 300 plus participants who are still with us, please
Right.
put in what topics on women's health you
Yes.
would like to see dealt with. This is the very first talk. Thanks to MMA Pulau Pinang, Dr. Divagar, the chairman from MMA Pulau Pinang, and Dr. Mairin here, who
Mhm.
has, our inaugural speaker on our Let's Talk series on women's health. But please put down in the Q&A or chat box what other topics that you would find beneficial, because women's health is vast. It's not just confined to obs and gynae, right?
True.
So put down what you would like us to deal with. So coming back to so a shout out to all 300 plus of you who are still online. Coming to our next question. Um, Hi, Dr. Mairin. I believe this is your former colleague and uh, prodigy lah, from Hospital Seberang Jaya. How to
Oh,
advise a patient
mm,
is reluctant to start on COCP? I
okay,
suppose this is
how?
directed to
Yeah,
all those unmarried patients who, doktor, ini pil perancang. Kenapa kita kena ambil ni untuk I belum kahwin lagi,
yeah,
doktor. I belum bersama pun. Kenapa I
yeah,
kena, sorry
yeah,
lah, I can't say that in Chinese or Tamil, so I just took off in Malay lah, okay?
yeah.
Disclaimer there. So, yeah, how do we deal with those patients and prescribing COCP?
I mean, first of all, I need to know my patients very well. I mean, I need to know them well. Why is it they don't want COC? Is there any particular reason for it? So I think if you explore the reason behind it, most of the time you'll be able to actually help them to come, um, maybe either they agree to it, or at least you can think of another way. But for me, I go back to why is it they are reluctant to take COC? As Dr. Sivabala was talking about just now, some of them could be teenagers. And then the mother said, no, you think you're young, otherwise my daughter is going to end up having sex with everybody, blah, 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 blah. But we explain to them how it's going to work, for what, and especially if there's any added benefits. I mean, let's say they've got acne, you take this one, it might help them out. So it's just an extra added benefit for them as well, right? So I think it goes back to communication with the patient, finding out what is the reason behind it, who are there, is there any added benefits that they may be able to gain from this. So it all come back to that. Yeah.
Yep. Brilliant. You've got a few thumbs up for that answer. And okay, next one. Another question. Is there any role of complementary medicine in the treatment of HMB?
I haven't come across it. Maybe more for a pain, but to reduce bleeding, complementary. For bleeding itself, maybe not. For other things, maybe they want to relax their mind, maybe. But I don't have much study for complementary medicine and heavy menstrual bleeding. So sorry about that. Dr. Siva, you got
Because
any thoughts on it?
no, I mean, I think as obstetricians and gynecologists, I think we are guided by the palm coin slide that you put up earlier. So
Yeah,
bottom line is our brains are tuned to going back to palm coin.
yeah.
Okay, and then we find the reason and we manage it accordingly. So and again, complementary medicine in a KKM setup for obstetrics and gynecology, hands up. I don't think both of us
Yeah,
have much experience or exposure on
true.
that front lah.
Mm,
Yeah.
yeah.
Okay. Again, somebody has commented. I think the slide on palm coin, that slide
Mm,
you shared earlier,
mm-hmm.
illustration K, right? But
Yeah.
palm coin doesn't
Illustration.
really have a K. Should be for copper IUCD is the comment, and not
Uh,
levonorgestrel intrauterine system.
no, no. Actually, the K is just to show you what is inside that particular small picture inside there. But it's still palm coin. If you look at
Right,
it, there is a K, there is L, there is whatever, but that's not part of the palm coin. It's just to show the photo inside there. This is mean what is that inside there. So
right.
probably we
Okay,
just misunderstood a little bit. Yeah.
right. Um, so the next participant, for how long can we give maximum dose of tranexamic acid? I don't
Yep.
think there is a duration.
Hmm.
Tranexamic acid, I believe, is pretty safe with a very low,
Yeah.
very
Yeah.
low index for side effects.
Yes.
Uh, we've hardly come across anyone who
Mm,
actually, it may not
true.
manage
True.
HMB adequately in some patients because we have not identified
Mm,
the cause
yeah.
appropriately. It is first line. But again, if you do it in a cyclical manner for 5 days, in a lady with raised BMI, so you're giving
Mm,
1000 mg TDS, I don't, as long as her symptoms are addressed, I don't
Yeah,
think there's a time frame for how long we can, as
yeah.
long as she's happy to take it, there are no adverse effects, and
Mm,
the symptoms are addressed, I believe you can go with it.
true.
Um, Next one is Maltopher is said to have less side effects. What's your opinion?
I mean, that's what they said. And another thing that they say is it's better to be taken with food, right? And it's tastes better. So I mean, I have taken Maltopher before because I have heavy menstrual bleeding myself, and I only started treating myself probably since COVID time, which is a bit sad considering I'm an ONG specialist. But I've tried Maltopher before, and it's okay. A lot of women actually able to tolerate it. So uh, again, it come back to what works for that woman, what give them less side effects. But again, have to remember, elemental iron in Maltopher is about 100 mg, and I know there are people who are giving like TDS. Probably not a very good idea. Mm, right.
It's pleasant in the mouth, I suppose, compared to
Yes,
the
it is.
others. Yeah.
Yeah.
Next question. Can we give norethisternol continuously for 3 months for heavy menstrual bleeding?
I haven't really come up with that because most of the time what they do, but I'm sure it shouldn't cause any problem, except probably they're worried a bit about DVT. So I can't really comment on that because I don't really have um, much evidence to say you can give it for about 3 months continuously. Um, but if it's something that is almost similar like Provera, I'm sure it shouldn't be a problem. I don't know.
Mhm.
Do you have any idea about this, Dr. Siva?
Unless you've got an endometrial pathology
Yeah.
uh, for, with hyperplasia. So whether for 3 months treatment, but
Hmm.
as long as the her risk profile, again, it is not one size fits all. We need to
Yeah.
look at the risk profile for
True.
patients, individualized, and then
True.
you decide accordingly. Okay.
Mm.
Past medical history, again, coming back to medical school, past medical history, family history, risk profile, all that is important. So it's not one
Yes.
size fits all. Take this
Yeah.
and you will be cured. Yeah.
Yeah.
Yeah, we're not there. Thank you for the thumbs up. Um, so there are a few, thank you for the suggestions in the chat box as well for upcoming talk. Next one, we have, hello doctor, thank you for the presentation. How to convince women who prefer ubat kampung for her bleeding, example, air sirih.
Does it work? I seriously, I mean, I'll be very interested to find out whether it actually works. That'll be interesting to know. Um, Again, it come back to communication, finding out what is actually behind that particular reason, right? How is it affecting? I mean, if you know your patients very well, it'd be a bit easy. I'm not saying it'd be 100% all the time that you'll be able to convince them to take some treatment that you think is best for them, but at least you'll understand where they're coming from and you might be able to suggest something else that is a bit more acceptable to them. So at the end of the day, it comes back to knowing your patient well, having a rapport with them so they trust you, your judgment, and they are more free to be able to talk to you what their concerns, and you may be able to address such concerns. That's usually what I do with my patients.
Very nice, Dr. Myrin, you're a gentle soul. I would go ahead and ask them, I would tell them, I'm really sorry, but dekat hospital kita tak ada air sirih. So
That
how
works too.
and I appreciate that emojis again for sensing the humor, but why did you actually come to the hospital if you do not want to take what, or come to the clinic and you do not want to take what the doctor is given, I mean, but in this day and age, right,
Yeah,
we have chat gpt lah, we have,
I
hey, you
don't
guys,
know.
you better stop encouraging me with all those emojis. I see all those humor. I'll take off in a tangent, and it's past 9 o'clock already. But yeah, but honestly, I mean, we have these patients coming in, and then they tell you that, doctor, we don't. I can understand where they come from, but thankfully, right? Thank God we don't get these sort of too many of these patients in
Yeah,
the
true.
hospital. So I think my heart goes out to our primary care provider friends and colleagues, but
Yes.
you have filtered all these patients for us. So we don't have to manage them, lah. So thank you. Yeah. Um, right. Then next question is, what dose would you suggest for uh, norethistérone? What dosage would be the
Um,
question?
I think it's 5 mg. I forgot what I wrote in my own slides, but it's in the slides.
Right.
Mm. So feel
Right.
free. You can have the PDF version of it. I don't care. If you want it, just ask from Dr. Siva from MMA. I will give them the copy. You can have a look at it.
Yeah.
It's actually written there. Right.
Right. Yes. Whoever who wants, yep, I see a thumbs up, appreciating that.
Mhm.
So whoever who wants a copy of that PDF slide, right, just write in. You've got the MMA ad, and it will be in your mailbox. I have got a disclaimer here to make. There are some MMA members who say that their inbox is flooded with activity, so they don't want excessive emails from MMA concerning webinars and unnecessary stuff. So we need to treat this the other way around. If you want a PDF copy of Dr. Mairin's uh, presentation, you've got it from the doctor herself. She's happy to share it. Send in an email to MMA, and we'll make sure that our HQ would then send you an email with the PDF of those slides. Okay, invaluable. The time she has taken to put that, I mean, anyone who does a presentation would know she finished presenting within 25-30 minutes, but the time that went into putting that together, you know how long that would take. And right. Um, Right. So have we answered all the other questions, Dr. Myrin? Because what I see in my chat box
Mm-hmm.
are basically
Yeah.
suggested topics for the future. And I
Yes.
thank you all for that. Uh, Invaluable. The Women's Health Committee plan to have a webinar every month with different speakers to cater for the topics that you have put inside there. So this is our very first. And each month we will be going collaborating with different states, because at the end of at the end of the day, a webinar is a webinar. It's meant for a national audience. So thank you for being with us. Um, Right. So we've actually come to the very end. All questions answered in record time, um, 9:12. Okay, about 75 minutes, Dr. Myrin. Thank you. And you see all those appreciation and love there. Uh, Thank you, Dr. Myrin. Thank you, MMA Penang. Thank you, Dr. Divagar. Thank you all. Still more close to 300 participants online sharing their love and yeah, appreciation. Um, Right. Great sharing. Usually doctor will prescribe. Yeah, someone has asked, usually doctor will prescribe the cyclical norethistérone for how long? The cyclical version.
There is no maximum to it as long as it helps, actually helps to reduce HMB. Not a problem.
Yeah.
Yeah.
So in our practice, what we usually do is we give the cyclical
Mm.
variant for 3 to 4 months, and then ask the patient to have a menstrual calendar or an app, whatever floats her boat. Then we review back the patient in 3 to 4 months, as long as her symptoms are being managed, and we see whether it's worked for her or not. If in the next 2 to 3 months she's on the treatment but it's worsening, then we always put a safety netting. Come back sooner if you need to see us because your symptoms are not responding to the treatment. But if it's responding, then you review the patient in 3 to 4 months and you say, how are you doing? Right.
Yeah.
That your body has regulated itself to this medication. Would you like to try stopping for 2 months and then come back and see me or not? So if it has worked, then it's like a cepat dan tepat tuition class, like just like what Dr. Myrin did, refreshed all our memories with heavy menstrual bleeding, and your body has attuned itself. But if it's not working, then you may need to go back on those cyclical medications. So
Mm.
again, individualized care over 3 to 4 months, review the patient again sooner if symptoms are not improving, low threshold for referral to tertiary center,
Yes.
open collaboration, so on and so forth. So um, right. Somebody asked in the chat box, can we get the recording of this webinar? Thank you for that question. We plan to put it on our YouTube, MMA's YouTube channel. Um, not many people realize that MMA has got a channel on all platforms, meaning uh, we have it on YouTube. I do not know whether we have started TikTok yet, but maybe from this one we need to find a TikTok version or Insta stories, and because all our attention spans are about 2 minutes or so nowadays, so we will
Yep.
go with that. But we are expanding, so thank you for that. Um, right. And if there are no further, I see some, from the beginning, I've seen a hand up, but then when I ask whether there are any questions, nobody has put in their questions on the chat box. So in the interest of time, it's 9:15. I cannot thank Dr. Mairin enough, and I cannot thank the participants who have been such a great sport enough. And I would um, like to hand over the session before we conclude to Dr. Divagar, who is the chairman of MMA Pulau Pinang, as well as the person who has facilitated this on MMA Pulau Pinang's platform. So, and also a shout out to Mr. Dana, who is the IT head in MMA, for putting all this behind the scenes and making sure things run smoothly, seamlessly. So thank you, Dr. Mr. Dana. Dr. Myrin, final words from you, and then we hand over to Dr. Divagar. So thank you all. Final words from Dr. Myrin. Then we go to Dr. Divagar and we are closing.
So my only hope, please, please, please look for heavy menstrual bleeding, even if the woman doesn't say they have it. If they come even with iron deficiency symptoms, even without anemia, please look for heavy menstrual bleeding as one of the causes. So that's all from me. Thank you so much for your attention. Thank you one more time to MMA. Thank you, Dr. Siva, for helping me out with the questions.
It's a pleasure, Dr. Myrin. Thank you. And thank you all for being with us. Over to you, Dr. Divagar. Thank you.
Hi everyone. As we conclude this insightful session, I want to take a moment to thank each of you for your active participation in episode 5 of the MMA Penang webinar series. A special thank you goes to our esteemed speaker, Dr. Mairin Dolasi, for sharing her expertise and providing us with a deeper understanding of the management and challenges surrounding heavy menstrual bleeding. Your practical insights and comprehensive approach have undoubtedly enriched our knowledge. I would also like to express our gratitude to Dr. Sivabala Selvaratnam for his excellent moderation and for highlighting key points throughout this discussion. To all our attendees, your presence and engagement played a vital role in the success of this webinar series. I hope you found this session valuable and that it inspires us all to continue improving the care we provide to our patients. We look forward to seeing you in our upcoming sessions as we continue to bring relevant and impactful topics to the forefront of our medical community. Until then, stay safe and thank you once again for joining us this evening. Have a great night.